Welcome to Module 1 of Nursing 825. And in this module, it's on the interdisciplinary team. And the reason this module is first is it's really the foundation of things that we're going to be talking about all semester. It's a continuation from Nursing 824, and it's really one of the primary tenets of palliative care, that in order to meet the holistic needs of the patient and their caregiver, we need to function as an interdisciplinary team. So I would like to review, in addition to this PowerPoint, obviously there is a very nice reading in your text, chapter 38, that nicely reviews and adds to this presentation. There's also two articles that I have posted for you. One is the Nancaro article, which is a very easy read, and it talks about the 10 principles of good interdisciplinary teamwork, and it was a qualitative inquiry that the authors did, and really gives you some insight into the work of an interdisciplinary team. And the final article is from the National Consensus Project. You'll see it, NCP, and the National Consensus Project is a coalition for quality palliative care. And it really is an interdisciplinary consortium, and we'll talk more about that as we go through this semester. It's really foundational as we go through. It gives you how we should be doing palliative care. And it started back in 2001 when an interdisciplinary group of palliative care leaders met to discuss the standardization of palliative care. The latest iteration that you have is 2013, when the guidelines were updated, but it truly is interdisciplinary. So the National Consensus Project is a coalition of the American Academy of Hospice and Palliative Medicine, that's really the medicine arm or the physician organization, the Center to Advance Palliative Care, or CAPC, that's really an advocacy group, and the Hospice and Palliative Nurses Association, HPNA, and are all part of this consortium, as well as the PCRC, actually it's the NPCRC, which is the National Palliative Care Research Center, as well as the National Association of Social Workers, all met to update these guidelines. And that's your final read. You'll reference this multiple times throughout the semester. So let's talk a bit about an interdisciplinary team. We have one main objective for this module. It's to discuss roles and responsibilities of each member of the interdisciplinary team. And as we look at the interdisciplinary team, you can see that it comes is made up of multiple players and multiple disciplines. A caveat to this, though, and a caveat with many of our practices, as you can see in this video, everyone is in one place. That's one way an interdisciplinary team may function. You also may see a team functioning where they're in multiple areas, and they really have to collaborate and coordinate the care of the patient and the family. So teams can be in different areas, and that's an important part to remember about interdisciplinary teams. You can see on the right a functioning team, and that's in practice. One of the issues, and this is also highlighted in the chapter in your text, is that many of us, though, are educated in silos, I think on the left, as represented by the picture on the left, and that creates challenges. I mean, if we are educated in silos, then how are we expected to make this transition to be an effective functioning team member? There have been multiple reports from the Institute of Medicine saying this is a problem with our education. We're working to fix that, and obviously that is one of the foundational principles of the whole palliative care certificate, is that it promotes interdisciplinary education. How do you take everything in each one of those silos and then put it together to function at that table? It doesn't work if we educate that way. So we really have to be educated in an interdisciplinary way. Again, multiple pieces that come together to make this interdisciplinary team, as we've discussed in the past. And really the goal of this team is to provide optimal care. We have the patient and the family there in the center. You can see how all those bricks have to be coordinated, and they have to collaborate in order to provide optimal care for that patient and the family member. So some characteristics of an interdisciplinary team. Obviously, there's a multitude of skills and knowledge to provide complex, comprehensive care. Cannot be done by one single professional or discipline. Team members are interdependent. A good interdisciplinary team will improve patient-centered care and promote patient and family dignity and autonomy. You can see that when you look at an interdisciplinary team, they can become very complex very quickly in order to meet all the needs of the patient and the family. You can see this is adapted from the Center to Advanced Palliative Care, or CAPC, from their website, and it can become very complex quickly. Now we are talking about an interdisciplinary team where a group of healthcare professionals from diverse fields work together in a coordinated fashion towards a common goal for the patient. You also have to realize there may be intra-professional, where we have teams from the same discipline all collaborating on the same case. So, we may have palliative medicine and cardiology as well as, family medicine, all the group of physicians working together to meet the needs of that patient. But we are really focused on that interdisciplinary team. Now, the Nankara article nicely reviews the 10 characteristics of an effective team. Obviously, it takes a lot of work for a team to work well together. And what I would like to talk about a little bit is that teams are not always effective. They can be dysfunctional. It takes a lot of work to be on a team and to be a good team player. In fact, if your goal is just to get through your day, it's probably easier to function not on a team than it is to function on a team. What you can see is we look at the 5 dysfunctions of the team, and it's kind of set up as a Maslow's hierarchy of needs, with the base of that pyramid being an absence of trust as the main dysfunctions of a team. You can also see a fear of conflict, a lack of commitment, avoidance of accountability, and inattention to results is contributing to a dysfunctional team. But that trust or absence of trust really promotes the dysfunction of a team. And on the flip side, if we were making this a hierarchy of needs of a functional team, you would have trust as that bottom part of that pyramid. So healthy teams typically have one goal. They value diverse professional perspectives, knowing that, they may be experts in their field, but in order to meet the needs of that patient, to go back to those original slides, it's going to take that whole big circle to get this done. They promote a safe working environment, and typically in healthy teams, there's an equal power structure. So the combined perspectives of interdisciplinary team members are much more likely to meet the complex needs of patients and their families than any individual provider. And the characteristics of effective teams, again, you've read this in your text, as well as in the Nankara article, but they agree on a common set of principles, goals, and measurable objectives. The team may have a charter or, a set of practice guidelines or rules that they follow. They expect that competent individual members represent their respective disciplines' current practice standards. So each member of that team is functioning at the highest level of their discipline, and they're well aware of the current evidence and guidelines within that discipline. They share the responsibility for team functioning, and in addition to the common goal to meet the needs of the patient and family, there is work behind the scenes to make that a highly functioning, effective team. There's ongoing feedback in terms of team interactions, communication, as well as conflict resolution. Again, that bottom pillar is really trust. You have to trust each other. You have to trust that those team members are functioning at the highest standards within their discipline, and they know the current standards. What I would like to end with is a video, and this is from Alan Dow. Alan Dow is from VCU, Virginia Commonwealth University, and he is one of the preeminent experts on interprofessional education. He gave this lecture as part of the Harvard Macy Institute. It was a teaching institute for medical education that I attended, and I think it is just an exemplar summary of the importance of why we do interprofessional education and why we work on interprofessional teams as part of the work that we do to meet the needs of patients in clinical practice. Hopefully I can do this correctly, so I'm going to stop share here. And then I'm going to pull up this video and we'll start sharing again.
In this presentation, I hope to give you a
hang on here. Let me see here. I still don't think that I'm sharing the correct thing here. Let's try this again. The joys of technology. Hang on here. I still think I have one too many screens open. I apologize, folks. Sorry. Share screen. Desktop 2. Share screen. Okay.
Foundation for thinking about interprofessional practice, interprofessional education, and the future of healthcare. Throughout the Harvard Macy course, we think a lot about teaching. I want you to take a step back and think about healthcare for a few minutes. Really, our goal as educators is a healthier, stronger society. And this is the lens with which I want us to think about our educational efforts. In this regard, my objectives for this presentation are to describe the different reasons for increasing and enhancing interprofessional practice. In addition, I want you to be able to define interprofessional practice and interprofessional education. Finally, I hope as a result of this presentation, you'll begin to consider what the interprofessional practice movement means for your teaching. Even if you will not be teaching interprofessionally, I hope some of the themes from this presentation will be applicable to how you approach your teaching. I want to provide you with 4 reasons for increasing and enhancing interprofessional practice. Let's look at the first reason. The interprofessional practice movement was born out of the quality and safety movement. In 1999, the IOM's To Err is Human report stated that 50 to 100,000 people die each year from medical errors. As data around the causes of errors were analyzed, failures in interprofessional collaboration were noted to be a frequent factor. For example, here's data looking at the cause of sentinel events in U.S. hospitals. Sentinel events are big medical errors, like operating on the wrong limb or giving the wrong type of blood. You can see leadership and communication are consistently second and third across years. Poor interprofessional collaboration is often a big part of these leadership and communication failures. In addition, the top item, human factors, how individuals relate to each other and the environment. Often, interprofessional failures are a factor here. The point is that if you look across errors, interprofessional failures are the cause, or one of the causes, of 70% of medical errors that harm patients. This recognition led to interprofessional education being recommended by the Institute of Medicine as a key area for improvement for educations of health professionals. In turn, all of the health professions have implemented educational accreditation standards saying that programs must provide interprofessional education to their students. So that's the first reason for the interprofessional movement. The medical error crisis has led to emphasis by accreditors. But there's more to having a healthy society than just delivering error-free care. And that brings us to the second reason, to increase and enhance interprofessional practice. The Institute for Healthcare Improvement defined these dimensions of quality. I think they're a useful way to think about how healthcare should interact with society. The acronym they use is STEEP. Let's look at each letter. S is for safe. We've covered this. Basically, we should not make people sicker when they interact with the healthcare system. T is for timely. Individuals should have access to care they need and when they need it. E is effective. Effective is providing the care the evidence says we should, and not providing the care the evidence says we should not. E is efficient, meaning we should not be wasteful. In the US, we spend 18% of our GDP on healthcare, and if the current trajectory continues, it will bankrupt us. That's got to change. It will be a dominant issue over the next 30 years. While healthcare spending in other countries is not as out of control, other countries also struggle with the cost of care. The third E is equitable. And from my perspective, this is the most important dimension for several reasons. First, in the US, we have huge disparities in care. It's shocking how two children born 5 miles apart can have a life expectancy that differs by 7, 8, 9, even 10 years. And the biggest predictor of this difference? Race. Second, if you look at what drives costs and poor health outcomes in the US overall, much of it is these disparities. We have not handled these issues well, at least in the US. Finally, I think this is the most invisible dimension of quality. What do I mean by that? When I teach my students and ask, tell me how to measure the quality of care, they come up with the other 5 dimensions pretty easily, but they rarely come up with differences in equity. Think about it. We always look at statistics in terms of averages or medians across populations. What's the average life expectancy? What's the infant mortality rate for an entire population? And these are important metrics. The other thing we should be asking is, tell me about the folks that are at the bottom. Which people are dying young? Which babies are not thriving? We've only started asking these questions recently, and we still have a long way to go to close the gap. Finally, the last dimension of quality is patient-centered. We want care that follows the preferences of patients. Another way of framing these goals for a healthcare system is the triple aim. The triple aim is a little bit more straightforward than the dimensions of quality. It says that our healthcare system should have 3 aims. First, we should improve health outcomes. Second, we should decrease per capita costs. And third, we should enhance the experience of care. You can see the overlap with the dimensions of quality. The point is that no matter how you look at the healthcare system, it's complicated, and there are lots of different things to think about how they interact with each other. So how are we doing? Here's data from 11 countries, including the US on the far left. In the first column, you can see the categories in which the countries were ranked. In the other columns, you can see how other countries did. While the Harvard-Macy program is an international program, let's just focus on the US for a minute. You can see the US overall ranks 11th of 11. That's disappointing. But let's look a little closer. In quality care, the US ranked in the middle, even winning a bronze medal for 3rd place in effective care. Probably a lot of that has to do with the success of our educational system. But in other categories, the US has bigger problems. The US is last in cost-related problems, then your problems with access to care, last in efficiency, and last in equity. The US is also last in probably the most important category, healthy lives. That's sort of a roll-up of all those population statistics. Finally, you see that the US is highest in per capita expenditures. And that's not even close to that category. And the news gets worse. Society and the healthcare system are under increasing pressure because of shifting population demographics. Let me show you what I mean. Here we have a graph showing the population mix by age. So you can see the 15 to 64 is the largest group, less than 15 in the orange line, and 65 plus in the blue line. All of those lines are going up. But the big thing to notice is that the ratio between the number of 65 plus and the number of 15 to 64 people is shifting. Right now, there are about 4 working age people for every 1 person over 65. That's going to drop to about 2.5 to 1 over the next 20 to 30 years. This is going to put a tremendous amount of pressure on the healthcare system as we deal with adults with increasing complexity, increasing need of health services. And if we're starting with lots of problems already related to quality and health disparities, you can imagine the situation we're in. Not just a US problem too. Here you can see the global change in population. While the under 5 population continues to shrink as a percentage of the population, the age 65 and over population continues to grow. Finally, here's a global map to give some detail to the idea. Here, the maps compare the percentage of population over 65 between 2015 and 2050. Note that the world is turning bluer, or perhaps grayer, overall. Europe is the bluest of all, but all the countries with lots of people, China, India, they're becoming increasingly blue. The point is that we have a healthcare system that is already under a tremendous amount of strain, and now we're heading into a period of historical demographic challenges. How do we respond? Clearly, increasing and enhancing interprofessional practice is part of the answer to provide the healthcare workforce that these people need. We cannot meet these challenges without better collaboration across professions. So there's two strong policy reasons to increase and enhance interprofessional practice. We need safer care, we need better care overall, particularly with the aging population. But I think it's the next two reasons that actually motivate us to think differently about what we do as educators and healthcare practitioners. I want to start by looking at our individual healthcare practitioners. This is my data, or rather the data of my teammates. We surveyed the nurses, residents, and hospitalists on 2 of the medical units on which I work. One of the things we asked was about the level of burnout. Here are the scores. You can see in the far left column the levels of burnout ranging from 0, I had no symptoms of burnout, 4, I felt completely burned out and often wondered if I could go on. You can see that most people across roles were level 1 or level 2. Very few were level 0. It's actually surprising when you think about the pressures of the environment. And a significant minority were level 3. Think about these level 3 folks for a second. They're miserable. They're probably not taking good care of their patients. And they're probably making other colleagues miserable. It's probably a vicious cycle that would be pretty hard to break out of. We then looked at perceptions of interprofessional collaboration in relationship to burnout. What we saw was a statistically significant correlation between interprofessional collaboration and burnout. I don't know what the causality is here. Does burnout cause worse collaboration, or does worse collaboration cause burnout? But clearly, many of my teammates are struggling. How we collaborate is related to those struggles. And at its most extreme, this is a story of tragedy. Recently, there has been a lot of attention paid to physician suicide. 400 physicians a year commit suicide. Most are young physicians, struggling in a job they thought they would love but don't, and feel like they cannot escape the weight of student debt and external expectations. In the suicide notes left by some of these individuals, one theme that emerges is the feeling of needing to do it alone, of shouldering the burdens of being a physician alone. I can't help but wonder if we could have saved some of these bright young people if we had been more collaborative in the workplace. The fallout from the pressures of healthcare practice is not only seen in physicians. In contrast to medicine, where physicians have lots of financial barriers to leaving the field, nurses see a different pattern. Nursing data where newly graduated nurses were asked how long they plan to stay in the field. The key point is that 5% say less than 1 year, and an additional 90% say 1 to 2 years. Nursing and other health professions spend a lot of resources training healthcare practitioners, only to see them leave the profession. What can we do to fix this problem? This challenge has led to an addition to the triple aim. In addition to the 3 aims of health outcomes, experience of care, and cost, people have added a 4th aim of practitioner satisfaction, creating the quadruple aim. Clearly, thinking about our teams and our work environments is something we need to take seriously, and enhancing interprofessional practice will be a part of that. Which brings me to the 4th reason for expanding and enhancing interprofessional practice. Let me tell you a story. This is Ms. B. She's speaking with Rachel, a psychology graduate student. Mrs. B was identified by my health system and a primary care provider as someone who uses a lot of healthcare services. She's been to the emergency room 12 times over the past year, and her diabetes is out of control. All of the things we typically do to help patients like her had failed. So we got the students involved. Rachel was part of a team of 5 students from medicine, nursing, psychology, and social work who volunteered to work with a few individuals identified as having challenging health situations. The students met with the patients to learn about their challenges and try to help them. Here you can see Rachel meeting with Ms. B in her house. You can tell by the information on her table and the diabetes supplies and whatnot that Ms. B has some chaos in her life. In fact, Ms. B is not only trying to handle her own problems, she's also raising her 8-year-old grandson. What the team realized in speaking with Ms. B is that she really faced 2 interrelated issues. First, she had trouble with her vision. This made keeping track of information such as appointments and medications a challenge. Second, she missed a lot of appointments because of challenges finding transportation. And Ms. B has Medicaid, meaning she could get free transportation whenever she needed it, but she struggled to schedule the transportation because of her vision and because she needed help organizing her life. So here's what the team did. First, they took Ms. B to the ophthalmologist to get an eye exam, some laser therapy to her retinopathy. Then they took her to the optometrist in the glasses store. You can see her here getting evaluated and fitting for the new glasses. Then they developed with her a process for better managing appointments and scheduling transportation. Here you can see Suzanne, a medical student, and Molly, an MP student with Ms. B. And to the right is the schedule and information for arranging transportation. The important part is this. Since the students began working with Ms. B, she has only been in the emergency department once. And both Ms. B and the students valued the experience tremendously. How the students helped Ms. B was not complex, did not take a lot of specialized training, but it did take someone getting into the community, understanding Ms. B's needs, and co-developing with her a plan to navigate some of the complexities she faces in her everyday life. This is really about people solving problems by working together. So these are the 4 reasons for increasing and enhancing interprofessional practice. The global emphasis on interprofessional practice is being driven by patient safety and shifting demographics. But really, there's a more personal story here, helping your colleagues and helping your patients that should really motivate us. So I'm going to close with a few more foundational thoughts about interprofessional practice and interprofessional education to wrap up this lecture. First, some definitions. These are the most widely used definitions for interprofessional education and collaborative practice right now. They come from the World Health Organization. IPE is defined as when students of 2 or more professions learn about, from, and with each other to enable effective collaboration and improve health outcomes. Note 2 things about this definition. First, it emphasizes improving health outcomes. That's kind of a novelty in health professions. It's important for us to think about. Second, note the prepositions. Like the Gettysburg Address, which stated government of the people, by the people, for the people, the prepositions matter here. IPE is not just learning about other professions or learning with other professions, it's learning from other professions. So each learner has a responsibility not just to learn, but also to teach. That's pretty cool. Here you also can see the definition of collaborative practice. You note I usually use the term interprofessional practice, so for the most part, they are interchangeable. Lastly, I want to leave you with this idea. In the education of health professionals, we focus, rightfully so, on developing professional expertise. We want our physicians, nurses, pharmacists, and therapists to be experts in their fields. Undoubtedly, this is a key ingredient in being a professional. But I hope you believe, and I hope I help support, the idea that healthcare practitioners also need expertise in collaboration. This is a separate and distinct set of abilities. We should think about them developmentally. As we train the professional expert, we also need to train the collaborative expert. There's just too much to be done to do it alone. I'll see you in class.
As you can see, that was an exemplar case on interprofessional education and how that correlates to interprofessional practice. I hope it gave you a lot of food for thought as we finish up this module and we move up into the discussion forum. Looking forward to hearing more about your experiences with interprofessional practice as you post in the discussion board. Thank you.